because it can precipitate syncope in them, and this patient can have fall and it can be life-threatening. The another set of patient is a cardiomyopathy patient, hypertrophic, who are already having a severe resting gradient. I'll not go into details of that. And the obvious patients are the one who are having mental impairment. Because while performing treadmill tests, we need cooperation from the patient. If the patient is already having some kind of a psychological or mental impairment, he might not be able to cooperate. And this can cause a fall and trauma to the patient on the treadmill bed. So these are the set of the patient in whom the treadmill test should be avoided. Now we will go in the depth of what is the value of this cardiac stress test or the treadmill test in coronary artery disease. First and the foremost is they can be used for the diagnosis of the coronary artery disease. Second is in the prognostication. So what does prognostication mean? In simple terms, the prognosis means what is the outcome of the disease. Suppose if someone have a bad prognosis, someone has a good prognosis, what does it actually mean? This prognosis word we hear more commonly in patients with the cancer patient. So prognosis means outcome. Suppose I say XYZ patient has this cancer and prognosis is very bad. That means what is the outcome? For how many years the patient will live or survive? How will be his quality of life? That is what prognosis is. So treadmill test or CST in patients who are already having a coronary artery disease. In such patient, we can use treadmill test for prognostication. It is a simple and logical thing. Patients who can walk more, who can perform exercise better way, obviously will have a better prognosis. However, patients who are not able to perform treadmill test or who cannot walk more or are not able to do their daily lives, obviously will have a bad prognosis. Third is it can be used for pre-operative evaluation in any non-cardiac surgery. So some patient is there who's already having a cardiac disease and he has to undergo some surgery, some non-cardiac surgery. How do we assess the risk of that patient? Many times we must have come across that patient requires fitness, cardiac fitness for non-cardiac surgery. So this is where the treadmill test comes in. If patient can have performed treadmill test without any symptoms and without any ECG changes comfortably, then we know that the risk of this patient, the cardiac risk of this patient while undergoing a non-cardiac surgery is less. However, if the patient has any changes or cannot perform a treadmill test, we know that the cardiac risk of this patient while undergoing a non-cardiac surgery is high. So that is how we evaluate the patient using treadmill test in patients who are undergoing non-cardiac surgery. Fourth thing is the assessment of therapy. So again, it's a very logical thing. A patient who had some heart attack underwent an angioplasty or maybe a bypass graft. After a few days or few months, he comes and he asks me, Doctor, I am still feeling anxious whether I have been treated completely or not. To reassure them, you can send this patient to the treadmill test. If he can perform treadmill test without any problem, without any ECG changes or any symptom, we can assure the patient or reassure the patient that see your risks are now minimal because you've been completely treated. However, if such patient again develops an ECG change or symptom, then we know that the either the treatment was incomplete or whether the patient has developed any new blockages or the stent has got blocked or the graft has got blocked. So that is how it helps in the assessment of the therapy. The another indication which is no longer used, but it was used in olden days, was the chest pain unit. So chest pain unit is like any patient who are present in the hospital with non-specific chest. If their troponin levels are normal, we send a troponin test and tell them normal. You can immediately subject the patient to a treadmill test. If the treadmill test comes out to be negative, it is a way of confirming that the chest pain is probably of non-cardiac origin, and you can safely send the patient. But nowadays, it is not used in the chest pain unit. Then for cardiac rehabilitation, it can be used. I have already discussed how it can be used. Any patient who is recovering from a bypass surgery or maybe a large myocardial infarction and has already undergone angioplasty, we have to ask patient to resume his daily activity. Many times patients are also anxious whether they can go back to the work or not. So in such kind of patients, cardiac rehabilitation is really important. And for reassuring them and in help, treadmill test is something which helps in the cardiac rehabilitation. First, you subject the patient to a low workload, means for making them do a treadmill test only for 5 minutes, maybe 4 minutes, and then you gradually increase. That way you can actually document if there is an improvement. Suppose at first time the patient is walking for 4 minutes and he feels I am now fatigued. Maybe you can continue that the same regimen and then again subject him to the treadmill test and then again see if there is any increment in the amount of work that is he's performing. So that is how it can help in the cardiac rehabilitation. Then the last is the disability assessment. Any patients of cardiac diseases who are very symptomatic, and they require a disability certificate. Treadmill test is one of the way doing that. If we can show that patient is not at all able to perform a treadmill test, or patient gets fatigued very soon, like before yeah, meds, that is the way of assessing the disability and maybe issuing the certificate. So this is the value of CST in any coronary artery disease. So what do we look for in treadmill test? So in treadmill test, or most of the physicians have this misconception that treadmill test is only about ECG, where it is not true. It is also about ECG and it is also about other variables apart from the ECG. And in fact, I would like to reiterate that non-ECG variables have got more value than the ECG variable. So what are these non-ECG variables, or what are these non-ECG parameters which we have to look for in patients who are undergoing treadmill test? The first and the foremost is the symptoms. Well, what kind of symptoms did patient have while performing the treadmill test? Did patient have any angina? Did patient have breathlessness? If patient had fatigue, at what level of exercise did patient have fatigue? Second thing is the functional capacity. Functional capacity means, in simple term, it is the capacity to perform any activity. Like if a patient was put on treadmill test, for how long could he walk or could she walk? That is the functional capacity. The third is the heart rate response. We look at the heart rate behavior of the patient while patient is performing exercise in the treadmill. And on that, we have derived few formulas which I'll be discussing. The fourth is the blood pressure response. What was the blood pressure at the baseline? How did the blood pressure increase? What was the maximum or the peak blood pressure which was recorded? In how much duration that blood pressure reached to that level? These all things are also recorded. The ECG variables, which of course we are going to talk about, is the ST segment changes, T wave changes, QRS duration, and any rhythm abnormalities. What are the things which we'll keep in mind before we advise any patient for treadmill test from our clinic? We have got a patient in our clinic. We have to send the patient for treadmill test. But what are the things first we will assess in the patient before advising him the treadmill test? First is the medical diagnosis or any past medical history, whether already patient is having in a pre-existing coronary artery disease, any past myocardial infarction, any history of angioplasty or bypass, any history of syncope or pre-syncope or any lung disease. Many times patient might have a lung disease because of which he might not be able to exercise. Sending such patient makes no sense, because unless and until they won't exercise, we won't have any meaningful endpoints or where we can have a diagnosis. Second thing is we have to look for symptom. What patient has, like whether patient has come with the symptoms of angina and whether that is associated with chest pain, jaw pain, or any arm discomfort. Whether patient is presented with shortness of breath, whether patient is having any palpitations, and these are whether associated with any physical activity. Many times, anginal symptoms can be associated with after eating a large meal also. The term for that we call is usually postprandial angina. Then at times patient can have symptoms with associated with emotional upset. So all these things have to be noted down before sending the patient. Obviously, the third important thing is what is the pre-existing comorbidities that patient has. This is important because this helps in assessing the patient's possibility that he might be having a coronary artery disease. So, comorbidities like hypertension, diabetes, obesity, dyslipidemia, and smoking. All these things should be noted. Why? Because if the patient is without a known case of CAD, we have to determine what is the pretest probability. Pretest probability is nothing but what is the possibility that if I send this patient for a treadmill test, it will actually or accurately pick up coronary artery disease. We'll talk about pretest probability later on. Also, we have to see whether patient had any recent illnesses, hospitalization, or surgical procedure. Many times, recent illnesses, hospitalization, surgical procedure is like a relative contraindication. You can wait before sending the patient for treadmill test, or you can look for any alternative test rather than treadmill test. Also, what are the medication, those are scheduled the patient is already on. We have a patient in clinic who has come and we are thinking of sending the patient for treadmill test. We have to review the medication. Many a time these patients are on beta blocker or calcium channel blocker. The problem with the beta blocker and calcium channel blocker are they are negative chronotropic, means they will suppress the heart rate. Whereas in treadmill test, we want the heart rate to go up. So these kind of patients need to be off medication for at least 3 days before ordering or before sending them for treadmill test. So that is why the review of medication is extremely important. The next is the ability to perform activity. Obviously, if the patient cannot perform any physical activity due to any kind of disability or psychological or mental incapacity, such kind of patient should never be sent for treadmill test or should never be advised. Other thing is you can do a complete examination before sending them for a treadmill test, like an cardiac examination, a respiratory examination, and a basic neurological examination to see that if the patient can actually walk on the treadmill. So how is a treadmill test performed? I'll first show you the picture. This is what a treadmill test actually is. If you can see, there is a treadmill, there is a patient, there are a lot of leads which are put on his chest, around his chest, and then these leads are connected to an ECG machine which displays the live ECG. There is a nurse who is checking the blood pressure. So ECG, blood pressure, and the heart rate, which itself is reflected in the ECG machine. These three parameters are actually recorded. And patient is also counseled before starting that if he experiences any kind of symptoms like pain or excessive breathlessness, he has to tell to the nurse or the technician. And if required, patient can also ask to stop the machine or to stop the test. So when we ask the patient to walk on the treadmill, there is a certain protocol, like how it is to be done. So the two most common protocol, I'll just tell briefly, is the step protocol and ramp protocol. Ramp protocols is not done nowadays, so I'll not talk about it. By saying stepped, that means we start the treadmill, we keep it at a particular speed for some time, and then we increase the speed. Then we again keep the next speed for some amount of time, and then we again increase. So it is like a step, it is like a staircase. So that is why it is called stepped phenomenon. So there are two protocols, the Bruce protocol and Norton's protocol. I will not go in details of this. You just have to remember that Bruce protocol is something which is the most commonly performed protocol these days. So Bruce protocol, I'll just tell superficially what it is. It consists of 7 stages, as you can see. And if you can see in the time column, the time written is 3 minutes. So there are 7 stages of 3 minutes. That comes to 21 minutes. And before that, there are two more stages called as the warm-up stages. So if you can see the speed of the treadmill is gradually increasing right from the warm-up phase up till the stage 7. Also, if you can see the fourth column, it is about the grade. Grade is nothing but the inclination of the treadmill. The treadmill keeps inclining or start raising in their height. So that is what is inclination. So inclination also keeps increasing. And in last column, like I told you, is the METs achieved. So METs is nothing but the energy expenditure or how much energy has the patient spent to achieve that kind of level or activity. So we can see, like for example, if we see stage 3, so it's written 10 minutes. So we know that when a patient has reached stage 3, he has already spent 10 minutes of energy. That means he could achieve that level of activity which required him to burn or expend 10 minutes of energy. So that is how we assess. So third stage is 10 minutes, second stage is 7 minutes, and first stage is 4.6 minutes. These three things we have to remember. Why we have to remember is first stage is 4.6 minutes. If someone who is not able to perform any activity above stage 1 or above 5 minutes is the someone who are actually really sick. That is why it is important to remember that. So what all things do we look for during treadmill test? We look for 12-lead ECG, we look for blood pressure, as I have already told, and we look for symptom. And these three things are seen, like I have already discussed, each stage is of 3 minutes. So these things are assessed at every 3 minutes during each stage. And once the patient has reached a specific meds or a specific stage, or if the patient has become symptomatic and we have stopped the treatment, even during recovery period, when the patient is at rest, we keep recording these three things: the ECG, the blood pressure, and symptom, even during the recovery. This we have to do until the patient heart rate and blood pressure returns to the baseline or resting state, or until the ECG normalizes. While doing a treadmill test, when would you stop the treadmill? Most common is ST elevation. Second is any drop in the BP. Third is if the patient is having angina or any other symptom. And fourth is the patient is having any ventricular tachycardia. Foremost thing is if patients request to stop, the patient asks to stop the test, we have to stop the test. So we all have this question: if I'm sending a patient a treadmill test, how well it can diagnose the coronary artery disease? So the ability of the treadmill test or CST to diagnose or pick up or accurately say that this patient is having coronary artery disease is based on the pretest probability. So pretest probability is nothing but what is the possibility that the patient might be having a coronary artery disease. It's obviously a common sense. Patients who are having typical chest pain, patients who are having diabetic, hypertension, these patients are, if they present with any chest pain, obviously it is more likely that they might be having an underlying coronary artery disease. So it makes more sense to send these kind of patient for treadmill test rather than the patient who's like very young, 30 years old, atypical chest pain, no comorbidity, because we know that the pretest probability is very less and this treadmill test will come negative in such. So that is what pretest probability means. So this is how we usually assess that which sets of patient needs to be sent for treadmill test. Like I have told you, the best set of patients for where the treadmill test should be considered are the one who are having intermediate probability. Intermediate probability means 50-50% chances. They might come positive also, they might come negative also. When I say high probability means we already know somewhere that there are multiple comorbidities, the chest pain is typical, the age is also quite high. In such kind of patients, you might not consider treadmill. Why? Because this patient definitely will have some coronary artery disease, so you can send this patient directly for coronary angiography. Whereas the patients who are having intermediate probability should be considered for treadmill test. Patients who are having low or very low probability, like as you can see, if the patient is asymptomatic or if the patient is having atypical chest pain, suppose a right-sided chest pain, and also if the patient doesn't have any comorbidities, patient is very young, patient doesn't have any addiction, these kinds of patients will have a very low pretest probability. So these kind of patient might not be sent for treadmill test. That was me. So that is why we have to pick up the patients who are in this age range, have a typical or probable anginal pain and have comorbidities. These are the patients for whom treadmill test should be considered. So what is the diagnostic power when we talk about facts and figures? In patients who are already having a coronary artery disease, just like I said, patients with intermediate to high pretest probability, the sensitivity and specificity is about 70% of treadmill test. What I meant to say is sensitivity is in 30% of the patient, it might still miss. And by specificity, I mean that patients who are having positive test might still have a normal coronary angiogram in 30% of the patient. That what sensitivity and specificity in simplest term is meant. So that is what it is. So what are the ECG variables which we should look for while interpreting treadmill test? So in ECG, for interpreting the treadmill test, we have to look at the ST segment changes first. In ST segment changes, we have to see whether there is any depression or elevation. These two things we have to look for. If there is a depression, we have to see what kind of depression it is. I'll come to the figures. Whether it is an horizontal or downsloping depression, or whether it is an upsloping depression. If it is an upsloping depression, we have to see the rapidity or the slope. If it is a rapidly upsloping, then it can be a normal finding with the exercise. However, if it is a slowly upsloping, again that can be a marker of an ischemia. ST elevation is obviously a obvious thing. It is a marker of ischemia. So this is what I meant. So as we can see in this figure, as we can see in this figure, uh, we can see there is a P wave, there is a QRS waves, there are QRS wave, and then after QRS wave, there is an ST segment, and then after ST segment, there is a biphasic T wave. So I have made marking also for this. If you can see, there is the one says PUQ junction. PUQ junction is nothing but a junction between the QRS and the PUQ segment, PQ segment. The J point or the junctional point is nothing but a junction between the Q where the QRS segment ends and where the ST segment starts. That is called the J point. ST8 is a term which is specifically used in interpretation of treadmill test or the cardiac stress test. Is nothing but the ST segment 80 milliseconds after the J point. When I say 80 milliseconds, we know that one small box is equal to 40 milliseconds. So two small boxes is 80 milliseconds. So two small boxes after the J point is called as ST80 point. So we have to see how much below the isoelectric point is that ST segment. Here the isoelectric point is nothing but the baseline from which you have to compare. The isoelectric point is the PQ junction. PQ junction is your isoelectric point. So from that we have to compare the ST80 point. If it is more than 1 mm, then there is definite depression. If it is less than 1 mm, then there is no depression. 1 mm means one small box, that is 1 mm. So we have to compare the ST segment at 80 milliseconds with the PQ junction. That is how we interpret. So if the depression is more than 1 mm from the PQ junction, it is flat or down sloping. I'll come to that. We can see there is the depression is flat. So if the depression is flat or down sloping at 80 milliseconds and at least in 3 consecutive beats. Why 3 consecutive beats? Because many times the patients are exercising, they might have artifacts. Artifacts means false depressions, but they will be seen only in 1 beat spontaneously or maybe in sporadically here and there. So for terming it to be abnormal, it should be seen in 3 consecutive beats, like here. So that is how it looks like. So this is the time, or this is the place where you will see that that ST depression is abnormal and the test is positive. ST8 is a thing which we have to remember. However, at higher rates, suppose that the patients achieve a rate of more than 130 per minute, we can measure the ST segment depression at 60 seconds after the J point. That is called ST60. But we will not go into that because that becomes difficult. For ST80, it is easier because two small boxes make 80 milliseconds. So that is the place where it is easier to locate and find out whether there is. So this is an ECG and this is how it looks like. As we can see at baseline, the topmost ECG graph, there is no depression. As compared to the PQ point, there is no ST depression. Whereas in the second graph, while exercising at 2 minutes and 50 milliseconds, we can see that the ST depression is there. It is a flat depression and it is definitely more than 1 mm depressed than the PQ segment. Same we can observe in the third strip also at 4 minute and 30 milliseconds. And we can see that during recovery also that change is still persisting. So that means this is the ECG type which is strongly positive. Something which came very early and persisting till very late even during recovery. This is called strongly positive treadmill test. So that was about flat and or downsloping ST segment depression. What about upsloping ST segment depression? Whether you should interpret them as normal or whether you should interpret this abnormal. So it is in simple terms, what we can see is we have to see the rapidity of that upsloping ST segment depression, whether it is rapidly upsloping or whether it is slowly upsloping. So if we can see the graph, this is what a rapidly sloping looks like. If you can see this, it's sloping quite rapidly, whereas slowly upsloping is something like this, like it is going upwards only, but it is slowly somewhere it is becoming flatter in simple term. So this is what is we call it as a borderline positive, whereas this is we call it as a normal because it can be seen in normal people also, and it is rate related changes because it is rapidly upsloping. This is the place where you have to make the demarcation. Now, the second changes is ST elevation. ST elevation, like it is very obvious, any kind of ST elevation which happens during the exercise test, stress test of more than 1 mm at 60 seconds in 3 consecutive beats is an abnormal response. At times, it can be seen after patients who have recovered from myocardial infarction also. And that is why immediately after myocardial infarction, we usually avoid doing treadmill test, and even if we do and find out ST elevation, it has got less significance. This finding decreases the frequency by 6 weeks. And ST depression does not tell us about the territory of ischemia. Like a patient might have an ST depression in V1 or V2 lead, but might have an blockage in the right coronary artery. So it tells about the ischemia, ST depression, but it doesn't tell about the territory. However, in case of ST elevation, if you find an ST elevation maybe in a V1 or V2, you can be sure that there is blockage in left anterior descending and not in RCA. So ST elevation is relatively specific for territory of ischemia. Again, while interpreting ST elevation, we should be cautious, whether it is in pre-existing Q waves or whether it is non-existing Q waves. If the patient is developing a ST elevation without pre-existing Q wave, then definitely it is positive test. However, if the patient is already having a Q waves and he develops ST elevation, that it does not indicate ischemia. I'll come to it to make it clear. See, this is the graph. If we can see, just see the last two strips. If the last two strips, see the first column is the baseline ECG strip, and the second column is the ECG strip at exercise. So if we see, it's written non-Q lead and Q lead. So the non-Q lead is where there you can see a tall R, and Q lead means there is a QS. We can't see R. So patients who are having an R and such patient have ST elevation, that is significant. Whereas patient who doesn't have R in that lead has QS already in the baseline, and such patient develop ST elevation on exercise, that has got no significance. There are also example of what is a normal response. As we can see in the first strip, the normal response is upsloping ST depression. Second response is a rapid upsloping, again that is a normal response. The third ECG strip is showing a ST depression. It is somewhat slightly flatter, that is a borderline positive. The fourth strip is a slow upsloping. We can see again that is a positive response. The fifth one is a horizontal, and the sixth one is the downsloping. Is that clear?
Yeah.
Yes. Apart from ST changes, we'll talk about some T changes also. Basically, T wave changes are non-specific. That's why we don't give much weightage to them. One finding is at times patient might have a negative T wave in the baseline, which can become positive during exercise. It's called pseudo normalization, but again, T wave changes have not much value for detecting ischemia. Even in normal ECGs also, if the patient, I'll just give one tip, like if a patient presenting to a clinic with a chest pain and in ECG there is just T wave inversion, it is highly unlikely that it is due to any coronary artery disease. The fourth parameter which we look about is for QRS duration. So QRS duration during exercise may increase in few of the patient. If we have to see at what heart rate it is increasing and what is the pattern. There is a pattern called as LBB pattern, and we all know there is a pattern called as RBB. RBB are the classical rabbit ear like kind of pictures in the V1, and LBB are like deep QS pattern kind of pictures in the V1. So that is what is LBB and RBB. So LBB at lower rates, if it's happening, then it is abnormal. However, if it is happening at higher heart rate, like more than 125, it can be a normal finding. Similarly, for RBB, it can be there in the old elderly people, but it has got no relevance. Like elderly people might have due to hypertension or RBB, or might develop RBB during the treadmill test, but it is like you cannot correlate it with the ischemia. One thing which we have to keep in mind that if patient is already having a left bundle branch block pattern in the baseline ECG, in our own clinic's baseline ECG, such patients should never be sent for treadmill test. Why? Because when there is already a baseline LBB, we know that LBB or RBB are also associated with secondary ST segment changes. And ST segment is usually in the direction opposite to the QRS direction. So if the patient is having LBB, they will already have a baseline ST segment depression. In such patient, the interpretation will become difficult. So this patient will have no benefit if they are sent for treadmill test. So in clinic, if the patient's ECG is done and patient is already having an LBB, such patients should never be sent for treadmill test. Whereas in patients who are having right bundle branch block, so in such patient, the treadmill test can still be interpreted and correlated. So such patient can still be considered for treadmill test. But for left bundle branch block, it is a complete no-no. Such patient should never be sent for treadmill test. There can be few rhythm changes also, like patients who are doing treadmill test, they can have premature ventricular beats. Occasionally, premature ventricular beats is a normal finding, and it can be there in young patients who are athletes and all. However, very frequent premature ventricular beats, like more than 7 per minute, or if the patient is having bigeminy or trigemy or any tachycardia, that is abnormal, and it is associated with increased mortality. Supraventricular arrhythmias. Supraventricular means like atrial tachycardia or atrial fibrillation or flutter, something which is arising above the ventricle, are narrow complex. These, if such kind of arrhythmias during treadmill test have got no relevance, they are not marker of any ischemia or coronary artery disease. However, such patient can have an incidence of atrial fibrillation in the late life. So the second part is interpretation is about the non-ECG variables. So non-ECG variables, most important thing is symptoms. So many times what happens, we send patient to any center which where the treadmill test is done by the technicians. Technicians will do it very mechanically. They will apply the ECG leads and they will make the patient exercise in the treadmill. And then they will stop once the patient has achieved a certain meds, like 10 meds or stage 3, and send up a report with saying that there are no ECG changes and the treadmill test is negative. But the story doesn't end over there. The patient comes to us, we have to ask patient whether while exercising did he have any symptom, which is usually not asked by the technicians who are performing the treatment test. You have to elicit that history. If patient says yes, I had chest pain, I had chest heaviness, or I had the same symptom for which you had sent me for the for the treadmill test. So that is where the you get a clue that okay, the patient had chest pain. So it is not actually a negative test, it is actually a positive test. So that is where the symptoms come. Symptom is something which we have to elicit. The history of symptom we have to elicit. It is not something like objective which will be picked up in the ECG or the BP machine. So we have to ask. We should make it a habit after every patient comes back with the treadmill test report. We have to ask them why that while doing the treadmill, did you have any kind of symptom? That is most important thing. Why? Because rather than ECG, symptom is more predictive or better predictor of presence as well as the extent of the coronary artery disease, and that is why it is important. Second most important is the functional capacity. So there are certain formulas which have been derived experimentally that what is expected functional capacity for a certain age based on age. Suppose there is a normal person of 30 years of age who can walk on treadmill for 13 minutes or maybe 13 minutes. And if there's another person who is not able to even walk for 7 minutes in spite of being in his youth, that means we know that something is wrong with that patient, and we know that he couldn't walk or is not able to walk as is expected from his age. So that is what is functional capacity. So that patient's functional capacity is impaired. So there is this formula which is based on the age. From there we get the predicted functional capacity, and then how much, what is the functional capacity of that patient while performing the treadmill test. Suppose that patient could run or could walk only for 7 minutes. That we compare. So ideally, it should be more than 80%. Suppose if someone is expected to walk at least 10 minutes and he could walk 8 minutes, that comes to 80%. So it will be considered okay, that's fine, that's normal. However, if that person could achieve only 7 minutes or 7 minutes or 6 minutes, that was we know that it is abnormal. So this is called functional capacity, and it is actually found in study that it is the strongest predictor of cardiovascular mortality. So it's not the ECG, but rather the functional capacity and the symptom which are more or strongest or better predictor of cardiovascular mortality. So what I mean to reiterate is again and again is we have to give equal weightage to ECG as well as other variables. And in fact, on studies, it was found that patients who are having less functional capacity, such as less than 5 minutes, as we can see in this graph, during 20 years follow-up, we can see the survival rates were least, like only 40% could survive. Whereas the patients who are functional capacity was more than 10 minutes, means approximately more than 10 minutes. When we convert it comes to approximately 10 minutes, was up to 85 to 90% survival. So we have seen that there is directly relevance with the survival uh, of the functional capacity. So that is the most important thing. Third non-ECG variable is the heart rate response. Means first is the what is the target heart rate. So we'll come across this on the reports very frequently. Target heart rate, target heart rate, target heart rate. For target heart rate, first we need to know the peak heart rate. So peak heart rate, just like I told you, there is a certain amount of activity which is expected from a person of some age, of a particular age. Suppose of age of 30 years of age of a person should be able to do at least 13 minutes of exercise. Same is the heart rate. When a certain person performs an activity, there is a peak heart rate which will he achieve. So that becomes an expected heart rate. Whereas that expected heart rate, 85% is what we are targeting for. Suppose, for example, someone's peak heart rate comes out to be 200. So 85% of that comes to 85% of that comes to around 170. So we have to make the patient exercise on the treadmill so that he reaches that heart rate. Because only after he reaches that heart rate, we are sure that we have put the patient on adequate stress, means we have made the patient's heart work to that extent so that we can pick up any abnormal clinical signs or abnormal ECG signs. So that is why it is called target heart rate. We have to achieve that heart rate while the patient is put on the treadmill test. So we have to calculate the peak heart rate and then make an 85% of the heart. That is how we do it. If the patient is already on beta blocker, we keep the target heart rate lower down, because as the patient is on beta blocker, he might not achieve a very high heart rate. So when we talk about heart rate, then an important concept comes. I will not go in deeper depth of that, but I'll just tell there is something called as chronotropic incompetence. Many a times in elderly patients who present with breathlessness, uh, we might subject them to coronary angiogram. We might subject them to 2D echo. 2D echo comes out to be normal. Coronary angiogram comes to be normal. But we notice one thing in ECG, that the patient's heart rate is 55, 60, 55, 60. There is the in those kind of patient are the patient who we should be subjected to treadmill test. Why? Because the normal response of our body is whenever we exercise, our heart rate increases. Why it is important for our heart rate to increase? So that it can increase the cardiac output and it can support the demands of the body. However, as we grow old, our sinus node dysfunction occurs. The sinus node becomes degenerated and weak. It is not able to increase the heart rate. That is what is called as chronotropic incompetence. So chronotropic incompetence is something where the heart is not able to increase the heart rate and meet or generate the demands or meet the demands of the body while it is exercising. So this can be picked up in treadmill. Suppose if the patient's expected heart rate is 150 beats per minute at 5 minutes or 6 minutes, but patient's heart rate could be achieved is only 80 beats per minute. We know that this patient is not able to increase the heart rate and is not able to cope up with the cardiac output. That is why patient is getting breathlessness or fatigue. So such kind of patients, in fact, are fit for pacemaker. So this is the place where the role of treadmill test comes, that diagnosing whether the patient is not able to increase the heart rate and then putting the patient on pacemaker. Then there is a third concept called as heart rate recovery. Normally, when we exercise, our heart rate increases, and the moment we stop exercising, our heart rate starts coming back to normal. This coming back of the heart rate to normal is called heart rate recovery. So there is a rate, there is a specific rate. Normally, within first minute of stopping the exercise, our heart rate decreases by more than 12 beats per minute. And by the end of the second minute, it decreases to less than 22 beats per minute. However, if the patient have any underlying cardiac disease, this recovery becomes slow. So in first minute, the heart rate decrease will be less than 12 beats per minute, and in second minute, it will be less than. So the heart rate recovery becomes slow. That means patient is having some underlying cardiac disease. That is how it helps to pick up the abnormalities. The fourth parameter which we look is the blood pressure response. So blood pressure response directly does not help in diagnosis of coronary artery disease, but it does tell us about lot of other things. So normally on exercise, what happens is as we exercise, our systolic blood pressure increases. Normally it goes more than 140 millimeters of mercury. Along with that, the pulse pressure also increases. And there is a product called as the heart rate into blood pressure or double product. So it is nothing but a simple multiplication of heart rate into blood pressure. This product is a derivation and it goes more than 20,000. So it indicates if the heart rate into blood pressure product is more than 20,000, that means our heart rate and blood pressure both have increased adequately to a good amount. If they don't increase, that means that exercise was inadequate. So in normal exercise, it will always go more than 20,000. That is called as the double product. However, while we are exercising, there is no change in the diastolic blood pressure. We have to keep in mind that. In patients who are having systolic blood pressure more than 210 or during exercises, these are the patients who are having a risk for development of hypertension in the future. That is called as hypertensive systolic pressure response. Second response which can be seen is exercise-induced systolic hypertension. So if patient starts exercising and the systolic blood pressure falls below the resting level, patient was already having a certain level of blood pressure like 140 millimeters or 150 millimeters of mercury. And once he starts exercising, the blood pressure rather than rising starts falling. Or in the second scenario, it increases from 140 to 150 and then starts dropping to 120. So this response is something which is abnormal. Like I told you, normally there should be a continuous rise. But if instead of rising it falls or it falls after rising to a small amount, that is called as exercise-induced systolic hypertension. Now this response is something which is indicative of severe coronary artery disease or patient might be having an underlying LV dysfunction. So LV dysfunction means left ventricular dysfunction. Patient is not able to generate adequate BP because of having a left ventricular dysfunction. A patient might be having an hypovolemia. Fourth response which we look for blood pressure is whether the patient is having any blunted systolic response. So as I said, when we start exercising, the BP keeps increasing. However, if the BP increase is less than 10 millimeters per meds, suppose in first stage the patient had a BP 140, in second stage rather than 150, the patient still has BP of 140 only or 146. That means there is a blunted systolic pressure peak. This can be because the patient is already on any cardiac medication like any antihypertensive, or it can be seen in the patients who are having dilated cardiomyopathy or again left ventricular systolic dysfunction. Other part is apart from the diagnosing part is the prognosis part. How do you assess the prognosis? Suppose there is a patient who has already recovered from a large myocardial infarction or a heart attack, and he's anxious that how long will I survive? You tell me, doctor. So how will you assess that? So there are multiple multivariable scores. So I have already spoken about the ECG variables and non-ECG variables. So the best way is that you combine all the variables. You combine all the relative variables because then you will have a more refined score. So there is a multivariable score called as Duke's Treadmill score. I'll not go in the depth of that, but it is the most commonly score which you will be seeing on the treadmill test reports. So this score is calculated as exercise time minus 5 into ST deviation engine. It is an automated score which is directly calculated by the machine and given. Important thing is how will you interpret it. So machine gives you a score of 10. So how will you interpret it? So it is interpreted like it is given as minus. So if it is more than minus 5, it is low risk. If it is uh, If it is minus 10 to plus 4, then it is moderate risk. And if it is minus 11, then it is high risk. That is how we calculate the PA. So this is how we usually interpret the treadmill test reports. I'll just summarize the entire thing. The first thing we look for is obviously the ECG changes like ST segment. If there is an ST depression of more than 1 mm and it is flat and downsloping, obviously you have to suspect coronary artery disease. If there is ST elevation of more than 1 mm in any leads, again, it is sensitive for coronary artery disease. Other non-ECG variables are like the symptom, functional capacity. If the functional capacity is less than 85% of the predicted, if the chronotropic response is less than 80%, if the recovery is, like I have already told, if the patient is getting ventricular ectopy, or if the score is less than minus 10, minus 20, or minus 30, then all these are indicative of underlying cardiovascular disease. So what are the other applications? We think of treadmill test only for coronary artery disease, but it is not there. It is not so. You can use the treadmill test for other cardiac diseases also, like for diagnosis of valvular heart disease. You can use it for adult congenital heart disease also, for cardiac rehabilitation and physical activity and exercise prescription, for disability assessment, and it can be used in peripheral artery disease also. So these are the places where you can use treadmill test. For peripheral artery disease, I'll just say that there is a term called as claudication, like lower limb pain when the patient is walking. Treadmill test, you can subject the patient to treadmill test and observe like whether patient is getting claudication or not. If the patient is getting claudication, at what time he is getting claudication. All these things helps in diagnosis of peripheral artery disease. Peripheral artery disease is something which is very common in diabetic patients. So these diabetic patients, apart from diagnosis of coronary artery disease, we should also look for peripheral artery disease. If a diabetic patient is subjected to treadmill test, just asking about the cardiac symptoms like angina or just looking at the ECG, we should always and must ask if the patient had any calf pain or claudication while patient was exercising on treadmill. These two things we can pick up easily in our clinic, peripheral artery disease and coronary artery disease. And that's why it's important that we should know it and keep it in mind. Also, treadmill test can be used for diagnosis and management of the cardiac rhythm disturbances like atrial fibrillation, ventricular peak excitation, long QT, and pacemaker function. I will not go into details of that. So the key take-home message is that treadmill test is the most common type of cardiac stress test performed today. It can be considered as a screening test for coronary artery disease. Non-ECG variables are as valuable as ECG variables. So non-ECG variables like symptom and how many minutes or how many minutes did the patient walk on treadmill, we should always look for it and not just the ECG variables or the ECG changes. Third thing is knowing the pretest probability increase the yield of test. Patients who are having intermediate probability should be sent for treadmill test. If the patient is having low or very low probability, such patients might not be sent for treadmill test because somewhere their yield will be less and the result or reports will come negative. Fourth is treadmill test can be performed for diagnosis as well as prognosis estimation of wide variety of cardiovascular disease, and understanding the indication and contraindication as well as precise interpretation is essential for cardiac care. Thank you.
Thank you, Dr. Amit. There are some questions in chat
Yes,
box.
yes,
Kindly
yes,
go
yes.
through it.
Okay. So one question is a young regular marathon runner with no symptoms. On some day while running, he gets MI. How to interpret this case? Baseline treadmill made mandatory for all runners of athletes, so they are asymptomatic. What is the advice? So treadmill test is something which is used for diagnosis of stable ischemic heart disease. Stable means patient is having a cholesterol plaque or a cholesterol stenosis in the artery, and when you subject them to the treadmill test, they have this mismatch, demand supply mismatch, and that's why he gets angina. Whereas a patient who gets an MI during a marathon runner, in such patient, what usually happens is coronary artery disease can be one cause of the death. Other things, there are other diseases also, cardiac disease, which can cause death due to very severe straining. I'll not go into details of that, but coronary artery at times what happens, these patients have 30%, 40% blockage, which does not get picked up in the treadmill test. But when you exert or when you put undue strain, these plaques get ruptured and then they cause thrombosis and cause complete occlusion. So yeah, treadmill test is a good way of picking up coronary artery disease, but it's not an absolute way or a foolproof way of picking it up. So yeah, we need few modifications in that, which is yet to come.
Dr. Amit,
Acha.
you talked more than 1 hour. I think the next topic, I think about 2D echo, we can take
Yes, yes, yes.
next week or some more time at time permits. We'll take question about today's topic today, then we'll move.
Yeah. I cannot see any more questions. That was the only question I could see.
No, one. I want to ask one question
Yes,
about
sir.
that.
Yes, sir.
The
Yes.
medicine had been stopped 2-3 days before the TMT test. Beta
Yes, sir.
blocker, like.
Yeah, beta blocker, sir, or if the patient is on a calcium channel blocker like diltiazem or verapamil needs to be stopped. Otherwise, even if they are continued, it's okay. But then we have to be informed to the doctor who is performing the test, because we then change the target heart rate. Just like I said that we have a target heart rate to achieve when the patient is on treadmill. So if we know that the patient is already on beta blocker, our threshold or other target heart rate is less. Because if we don't know, we will try to achieve and we might not be able to reach the end point.
Okay. Okay. Fine. Already lecture has been very minutely details and descriptively elaborated. Each and every minute thing has been classified into the lectures. Actually, it became more what you call just learning in the classroom. So we'll go through the 2D echo also next time,
sure.
because as this is the what you cardiac series, we would like to introduce to the our viewers. Actually, today we have talked on the TMT. Next time we can go with the 2D echo. Next time go with the angiography and plasty, everything.
Yes.
Thank you very much, Dr. Amit. We'll go
Yeah, I
forward.
would like to thank everyone, Navi Mumbai Doctors Foundation, Dr. Kure, Dr. Bagul, and everyone for inviting me and giving me this opportunity to share the learning. And I'll keep seeing you again. I
Yeah,
had
yeah.
tried to keep the today's talk a bit elaborative. See, we all think of treadmill test only when it comes to ECG, but
Mhm.
nobody talks about that. It is way more beyond ECG and
Right.
way more beyond than looking the ECG. Many times ECG comes normal, but like I said, you have to keep asking patient, did you have any symptom? Did you have any claudication? Which the technician would never ask. And that is the place from where you have to pick up whether it was actually really negative or was it positive.
Mhm.
Yes.
Sir, I wanted to ask one thing, that if there's any changes in the instrumentation of this test. Like recently, I heard that we can pick up minute changes at the earliest. Any change in the machines of treadmills test?
So the thing is, right now we are having a lot of work in artificial intelligence. So our eyes, what cannot appreciate, the artificial intelligence can appreciate. Like just I said, for us to appreciate a change, we have kept a cutoff of 1 mm of ST depression. Why? Because we can appreciate a change of 1 mm of depression. Otherwise, we cannot appreciate. But AI, like artificial intelligence, can even detect very early or very minute subtle ST depressions also. So, though we have not kept the criteria of less than 1 mm as a diagnostic, but still it can pick up and tell that, okay, we have to monitor this patient more frequently. In the future, might turn out to be a coronary artery disease. So that is how it is keeping. Then there is something called as late potential. I'll not go into details of that. So in the baseline ECG or during the cardiac stress test, there is some potential at the end of the QRS and before the T. Those are called late potential. Sometimes in the advanced or AI enabled machines can pick up those potentials. And then these patients are having late potential, and suppose this patient is having already suffered a heart attack or have a cardiomyopathy. This late potential can tell us whether the patient has an increased risk of sudden cardiac death. So a lot of advancements are happening in the ECG, but first we need to master our basic and the conventional treadmill tests.
Right.
One more, I think there
I
is a
think,
question in the chat box actually about the
Sharan,
CT
will
angio
take
and
this
all that.
question.
But already we have told that today is for the TMT sessions. So in next time we will go with the CT angio or 2D echo and all that.
Yeah, we'll
Because
discuss in
this
detail
is
about that. Yes.
test series is going to be continue. Thank you, Dr. Amit. Thank you.
Thank you. It was pleasure.
Yeah. Arun?
Yes. We.
Yeah. Now we will summarize the. Do you
Okay.
want to ask any more questions
No,
or
that's
we'll
it.
summarize?
We'll stop here.
Okay.
Yeah.
Fine. Thank you, doctor.
Thank you. Take care.
Okay. Bye.